Well, I'm the last speaker, and thank you for staying behind for my presentations, the two presentations. My name is Joseph Chu. I'm from Toronto, Canada, the colder part of the world. I think I've met some people who are from Sweden and Norway, so I guess that's comparable in terms of climate. The first presentation is on the COVID-19 research we've done since 2020. And the disclosure is that I'm the chair of research at an organization called CHAPA, representing Chinese Canadian Heart and Brain Association. It is a non-profit organization mainly dedicated to the study of health among the Chinese Canadians, particularly around heart and brain. And my study was supported by the Ontario Ministry of Health for our work. Now, we work as a team, and within the team, there are a number of cardiologists, clinical epidemiologists, and also senior scientists at a data center called ICES. It's the Institute of Clinical Evaluative Sciences. So I thank all these collaborators in making this research possible. Now, the objective is that I'm going to review with you the data we've collected with the help of the government in terms of the neurological and cardiac complication within the wave 1, 2, and 3 in Ontario, Canada. And we particularly was interested in the Chinese Canadian and the South Asians. Now, for those who doesn't understand Chinese, there's an English translation below. It's called danger equals opportunity. In Chinese, we call it 危機. Whenever there's danger, there's a chance to find out more. So that's the opportunity. Now, the development of COVID-19, I'm sure all of you are aware of. Wuhan was the origin of the coronavirus. And soon after the concern by WHO around March, in Ontario, which is the province of Canada, we went into lockdown. And this is where I started to assemble my team of researchers, because when we're locked down, we're not even allowed to go back to our clinic. And hence, the only way to do these type of research is by virtual. So what we have found is that over the time, we have accumulated these data, and the information is listed in here. These data were collected up to around 2022, and you could see that there were over 45,000 Canadian deaths. And in Ontario, it's about 14,000. Now, these graphs represent the incidence of COVID-19 and death, the cases developed. And we could see that the South Asian and the Chinese are much higher in incidence compared to the white Caucasians, which is on the bottom part of the slide right there. And this is wave 1. As wave 1 and 2 continues, we could see that the main population of people that are affected are mainly in the 20s to in the 40s. And we do have the elderly population, which I'll elaborate on, which are affected because when we're locked down, even in long-term care facilities, these elderly people are not able to be sent to the emergency room because the hospital were sort of overwhelmed by the pandemic. So with the help of the Clinical Evaluative Sciences, which is the government-funded agency to look at statistics, we're able to analyze these data. Now, with those data, we presented our paper in 2021, and this is the wave 1. And then we have a second paper that was published in 2022. It's on wave 1, 2, and 3. So why do we want to look at that? Well, first of all, Chinese, Canadian, and South Asians represented about 50% of the population in terms of visible minorities. Now, the other political roadblock we came across was that the government wasn't interested to review ethnic data. The specificity is high, but then the sensitivity is not as good for the South Asian because there are certain last name among the South Asians that could overlap with Middle Eastern ethnicity. So the two things that we're looking at mainly is cardiac and neurological complications, and the primary outcome is death. Now, we also have a multivariate logistic regression model, and I'll show that at the end. Now, these are busy slides. Basically, what we like to summarize is that there were over 500,000 population that we looked at. And among them, there were about 15,000 that are Chinese Canadian, about 46,000 that are South Asians. And we could see that the mean age of the Chinese are actually a bit older compared to the general population of South Asians. We also have found that the South Asians come from a lower income quintile. So most of these South Asians are mainly in the manufacturing, in the logistic, work. Now, again, this is a very busy slide. What it highlights is a very common index that we use. It's called Charleston Comorbidity Index. Now, what it does is that we look at before you get COVID-19, are you healthy or are you very sick? But what we found is that majority of these people are healthy people. They have very few comorbidity before they develop COVID-19. And that's part of the tragedy where we are being hit in the most productive population segment of our society. Now, again, the slide here basically using the blue representing the Chinese and then the orange, the South Asians. From left to right, we could see the crude rate per 10,000 population. Death, much higher among the Chinese, cardiac neurological complications, hospitalization or emergency room visit, hospitalization alone, ED visit alone. Again, we could see that the Chinese and the South Asians all are much higher in incidence compared to the general population. Now, if we break it down, we look at the age under 65 versus age over 65. And again, you can see that a lot of these people less than the age of 65, they make a lot of emerge visits, hospitalization. Why is that? Well, even the GP medical clinic is closed. They cannot get medical help. So in other words, the best place for these people who are sick is to go to the emergency room. And that's why the hospital system was so overwhelmed. Now, again, for the age of 65, you can see the mortality is much higher because these are the elderly folks that are being locked up in the long-term care facilities, and they cannot even go to the emergency room to get medical care. This is again by long-term care, again much higher within the elderlies, and also much higher among the Chinese and the South Asians compared to the general population. And if you're not in long-term care, obviously these are much healthier people. The death rate is much lower because you're more healthier, but then the hospitalization and emerge visits continue. Now, this is again a very complicated slide. Now, basically what it means is that on top is wave 1, and then we have wave 2, and then we have wave 3. Now, remember, at least in Canada, beginning of wave 2 is when we start having vaccination. So as wave 3 came around, a lot of these people are either partially or fully vaccinated. So obviously these number drops, mortality drops, and also complication drops. So again, we could see that in wave 2, the South Asians have a little bit more hospitalization, again, mainly relating to a working population among the South Asian group. Now, basically what it means is that the 30 days all-cause mortality are much higher among the Chinese. It's almost 1.4 times. But the overall neurological complication rates for the general population was very low. It's only about 0.3%, but it's still higher among the Chinese and lower in the South Asians. The type of neurological complication, encephalopathy, is the commonest one. Basically, these are people are delirious or confused. Obviously, when someone is hypoxic due to COVID-19 with respiratory distress, the first thing they're being affected is this delirium and confusion. There are cases of stroke, including hemorrhagic type or ischemic type. There's some Parkinson's disease. Remember, 100 years ago, there's a condition called encephalitis lethargica due to the flu infection during the 1912 flu influenza pandemic. There are no cases of encephalitis, meningitis, Guillain-Barré syndrome, or myositis among the Chinese and the South Asians, but there are cases in the general population. Now, this is just a literature review when we look at what has the world reported in terms of complication. And we could still see that encephalopathy is still the commonest, but there are still other reports of stroke, seizure, and others. So we did this multivariable logistic regression analysis, and the conclusion is that ethnicity is still a major determinant of 30 days overall mortality, cardiac and neurological complication, hospitalization, emergency room department visits. So this is an important conclusion because, as we could see, again, these mortality, cardiac neurological complication among the Chinese are much, much higher than the general population. Now, just a few words about coronavirus. Why is it more prevalent and more serious among the Chinese and the South Asians? So we know that there's a spike protein along the virus, and the spike protein requires a receptor called ACE2. And once this virus is infected into our lungs, then a whole cascade of neurochemical, biochemical changes occur and causing a cytokine storm. And there are damages to different target organs like the liver, the heart, the brain, and the kidneys. And a lot of time, patients just die from multi-organ failure. So the reason why maybe Chinese are more serious in terms of complication is based on one of these studies I looked at. And what they have found is that there's higher density of ACE2 receptors among the East Asians. East Asian meaning then Chinese, Koreans, and Japanese, while the ACE2 receptor density is actually lower among the South Asians. Maybe there's a protective effect for South Asian groups. So these are good sort of explanation why there is some difference clinically. So the findings, as we discussed, is that encephalopathy is still the commonest neurological complication, but a lower incidence of stroke that we have found in the current study compared to the reported literature. There are some limitations. However, we have done further study in 2024, 2025, and this concern about lack of vaccination status, we were able to clarify that in our subsequent two more publications, both regarding to cardiac complications and neurological complications from COVID-19 vaccines. So in conclusion, what we have found is that ethnicity is an important determinant of outcome among the Chinese, Canadian, and the South Asians with regard to COVID-19 complication. Now, when we had these data, we presented back to the Ministry of Health and the Ontario government, and we're hoping that in future pandemic, the government will look at these data and try to allocate appropriate health resources for the appropriate visible minorities. I think this is very important. As we practice medicine in the 21st century, we always consider what we call precision medicine. So not only look at the age, the sex, etc., past health, we also look at ethnicity because maybe different ethnic groups have different kind of responses to treatment. For a lot of these follow-up plans, we've already done, as I say, the publication on the vaccination. These are the publications and references. The two top ones are the one that we have published. As I say, there are two more additional publications, and you can do Google search under my name as a main author for this. Now, lastly, I want to invite you to come to visit Toronto, Canada. This is the CN Tower, one of the top buildings around the world, and you can see baseball game here, and that's a Sky Dome. And thank you very much for your attention.